Assalamu alaikum. Good morning, good afternoon, and good evening. Happy Eid to those of you who are celebrating. For us, it is going to be the last fasting day of this year. Yeah, I'm gonna share it. Thank you, Sanaha. All right. So today we're gonna continue doing the gastroenterology, but we will quickly cover the acute pancreatitis, which is very commonly tested. It comes in different station as history taking, as a consultation, differential diagnose, very commonly tested differential diagnose and management. So we are going to cover acute pancreatitis. So in the form of being a topic or a station of internal medicine or emergency case. So this might be one of your station. Since it is very high yield, for those of you who are preparing for NACOSCI, I wanted to cover this station. I'm pretty sure most of you are familiar with acute pancreatitis, but by the end of this lecture, you should be able to recognize the classic presentation. Also, you should be able to use the practical diagnostic framework, differential diagnose of the differential diagnose and differentiate the common causes, which we have mnemonic, which is called I Get Smashed. Prioritize supportive management, which is going to be part of the differential diagnose and management. Also know when to escalate. All right. So in terms of recognize, we will go one by one to cover all of them, but just quickly to cover all the lectures at the beginning. So sudden severe epigastric pain. If you are given a station that the patient has sudden severe epigastric pain, and that pain is radiating to the back, and the patient has nausea and vomiting, especially if the patient has severe vomiting with it. Not only that, if the patient is leaning forward, gets better. If the patient is lying down in supine position, getting worse. So think about pancreatitis. So before you enter to the station, you should have at least an idea of that this abdominal pain is most likely acute pancreatitis. So I have to structure my station based on that. Use the practical diagnostic frameworks. This is very important whether you're doing the MCQ one or NACOSCI, that how it is approached when it comes to diagnostic framework. So 2 out of 3 criteria has to meet. One of them is the characteristic of the pain. So why we are insisting or talking more about the pain characteristic, because it is very important when it comes to diagnosis. Why? Because it's very characteristic if you have an abdominal pain, especially if it is in the upper epigastric area or upper abdomen, and it gets better when you lean forward, and it gets worse when you're lying down in supine position, and also it is radiating to the back, and it is associated with the nausea and vomiting. Usually, if it is an emergency case, the patient would be having vomiting. Okay. So, other than that, lipase and amylase elevation, which are the very commonly tested enzyme in the licensing exam, and out of both of them, lipase is more specific, and amylase, if it is 3 times than normal, then it is pancreatitis. So in MCQ1, when they're testing you about the pancreatitis, they might ask you which one of the following enzyme is more specific. Your answer will be lipase. Or they might give you a scenario about somebody that who has an abdominal pain and the amylase um, and, result or number is 3 times the normal range. That should give you a clue that I'm dealing with the acute pancreatitis, and also imaging evidence. So if you have characteristic pain, if you have high lipase in amylase, and you have imaging, then you have pancreatitis. If you have 2 out of 3, still you have the diagnosis. So differentiate common causes. especially gallstone, very commonly tested, that you need to know that these are the two most common cause of pancreatitis, gallstone and alcohol. So gallstone is around 45% of the time and alcohol is around 35% of the time. And other than that, when you're doing a nakoski, so you should be very, very specific about using these two, that I am ruling out this and I'm ruling out that. So my most common suspicion is the gallstone, then the alcohol, then I'm going after the other causes like medication and so on and so forth, which we simplified in a mnemonic, not me, but it has been there for a while, and all the resources that we are using for the licensing exam, it is a mnemonic that is called I Get Smashed. I will show you every single one of them. So prioritize supportive management. Always the management when you are dealing with a differential diagnosis and management, remember that you need to start with ABC. If it is emergency case, always start with ABC. If it is in the hospital, you start with the ABC. If it is in the clinic, then obviously the patient is walking, the patient is not in a severe condition. Probably you're dealing with a chronic pancreatitis rather than acute pancreatitis. So the management approach will be a little bit different. So for the acute pancreatitis, always ABC, goal-directed IV fluid, analgesic, antiemetic, early monitoring, and nutrition when tolerated. So it means you need to start the patient on oral nutrition as soon as possible, as soon as the patient can tolerate. So know when to escalate if you are suspecting cholangitis, persistent organ failure, necrosis, hypoxia, acute kidney injury, ongoing biliary obstruction, the red flags. So basically, we need to pinpoint the red flag. NAC OSCE payoff, history is station. So usually, again, the reason we are doing it, it might come as a history taking. So we need to cover all the OCD, PQRST, UV triple A, which is the structure for the pain, right? And then the associated sign and symptom, which is which is part of the triple A, right? Associated sign and symptom, very important to cover. Then counseling station, you might get as a counseling station, explain what is pancreatitis in a lame language and how you can convey this message to the patient, and how do you educate the patient. Differential diagnosis station present a structured emergency plan to the examiner. So exam phrase to remember, I would stabilize first. Again, always we do this in emergency case. If you're dealing with an acute abdominal pain, always stabilize the patient if the patient is not stabilized. Or you can just say, I will start with the ABC. First, confirm the diagnosis, assess severity, and actively look for the causes, because pancreatitis has huge number of causes, but the most common cause are two. The first one is gallbladder, the second one is alcohol. Now let's dive deep into what is happening in acute pancreatitis. So it is a premature or an early event in an intracellular enzyme activation, especially trypsin. This might be in the exam in terms of mechanism, like which enzyme prematurely get activated and cause the autodigestion of pancreatic tissue. So trypsin, please keep it in mind. And gallstone may obstruct the ampulla. This might be also in the exam. Which part? Ampulla, pancreatic duct, while alcohol predispose the gland to enzyme activation and cellular injury. So out of all of this, remember the trypsin, which is the premature activation of this enzyme, and for the gallstone, ampulla or pancreatic duct. Okay, or alcohol causes the injury, pancreatic cellular injury due to enzyme activation. Local inflammation causes edema, fat necrosis, pain ileus, and third, pacing of spacing of the fluid. A strong systemic inflammatory response can lead to hypovolemia, ARDS, acute kidney injury, shock, and multi organ failure. We will talk about the systemic inflammatory response, which is very important to understand because it shows the severity. So, in exam ready wording, acute pancreatitis is acute inflammation of the pancreas caused by premature enzyme activation inside the gland, producing local injury, and in severe cases, a systemic inflammatory response. Now, the major cause, as I mentioned before, number one, which is the most common cause, is gallstone, which is 45%. And 35% it is alcohol. Then the other causes could be hypertriglyceride, but remember, in MCCQE1, they may give you a scenario of someone with the abdominal pain and the triglyceride is more than 1,000. If you see anyone with the abdominal pain and triglycerides more than 1,000, think about acute pancreatitis. Okay? Or it might be one of the options. Just remember, triglyceride over 1,000 has a strong relation with acute pancreatitis. Hypercalcemia is present post ERCP pancreatitis. Usually, we can use ERCP for the treatment and diagnose, and it could be the reason for the pancreatitis. So keep these both in mind. Medication and trauma, tumors, and also example says gallstone first, alcohol second, which I did mention it. Now, in terms of clinical presentation and bedside clues, these are the things that we have to know about the pancreatitis. For example, what is the typical symptoms? We did talk about it, right? It is a sudden, severe epigastric pain, pain reduced to the back, nausea, and repeated vomiting. Remember that they will mention unremitting or repeated vomiting. So if you have anyone with acute abdominal pain, unremitting vomiting, the pain reduced to the back, and also the pain gets better when the patient lean forward, it could be acute pancreatitis. May feel better leaning forward, which is I made it red, I made it bold to stand out. Please keep that in mind. They might mention it indirectly, so keep that in mind. Abdominal distension, Elias, can occur. Think gallstone pancreatitis if the right upper quadrant biliary colic history is positive. If your patient, remember, these are the clues. They are not mentioning it directly. They might give you they might mention these clues in the scenario. For example, your patient has right upper quadrant pain. The patient is a little bit jaundiced, and the patient ALT is more than 150. So when you do the ultrasound, there's a dilation of the duct. So these are all pointing toward to the gallstone-induced acute pancreatitis. So if you have ALT more than 150, if you have jaundice and you have right upper quadrant pain or history of biliary colic pain, and when you do the ultrasound, you have dilation, think about gallstone-induced acute pancreatitis. So examination, epigastric tenderness and guarding, tachycardia, dehydration, fever may or may not happen. Jaundice suggests biliary obstruction, which we colon and gray Turner sign, or they're very late and hemorrhagic sign of pancreatitis, but they're not very specific. They're not happening early stage, they are happening very late, and they are showing very serious condition or hemorrhagic pancreatitis. I will show you the picture. Immediate red flag, these are very common, like commonly tested, whether you're doing MCQ1, whether you're doing the NACOSCI, and please do not forget to cover it if you're doing history, because they are expecting you to mention these red flags, or at least to be cautious about these red flags. If you're not covering the red flag, you're losing a lot of mark. So hypotension, shock, hypoxia or tachypnea, confusion, oliguria, acute kidney injury, sepsis, or cholangitis, sign and symptom or picture. Differential diagnose, biliary colic, cholecystitis, cholangitis, perforated peptic ulcer, mesenteric ischemia, inferior MI, bowel obstruction, or other acute abdomen. So exam script, I would treat acute pancreatitis as most likely diagnosis. So if you're doing a differential diagnosis station, right? So this is how you start it. So I would treat acute pancreatitis as most likely diagnosed. Why? I put a few dots, right? Why? Because this that I found in the patient history taking. For these reasons, I think it's most likely pancreatitis, and I am going to go ahead and do the treatment. But I would also keep biliary diseases, perforation, and mesenteric ischemia, and the differential until assessment is completed. And then why I'm thinking about these other differential, you need to justify. So this is the colon and gray Turner signs. This is how it looks like, but again, they're in the very late stage. They don't happen in the acute stage right away or early stage. So cause of pancreatitis, if you guys remember, I mentioned the first most common cause is gallstone, 45%. Then alcohol, 35%, the second most common. Then we have a general cause, which is I get smashed. There's a mnemonic that says I get smashed. So I stands for idiopathic, G stands for gallstone, E stands for ethanol or alcohol, and T stands for trauma. Again, the ERCP could be diagnostic and treatment, therapeutic for this condition, and could be the cause as well. S for steroid, and M stands for the mumps and other infections or viruses. A stands for autoimmune, and S stands for scorpion sting, which I hate the most. Hyperlipidemia, hypertriglyceride, which if it is more than 1,000, hypothermia, and emboli. D for drugs, azathioprine, estrogen, and there are a lot of other like acetaminophen. There could be, for example, antibiotic, and so on and so forth. There's a huge list of it. Okay. And this is how the Gray Turner syndrome uh, looks like. Acute pancreatitis, differential diagnosis, and NAC-OSCE. So biliary differential, biliary colic, acute cholecystitis, acute cholangitis. For the GI surgical mimics, perforated peptic ulcer, mesenteric ischemia, bowel obstruction, or other acute abdomen. Must not miss extra abdominal, for example, inferior MI. Remember this, consider ECG if features are atypical. Always mention dangerous mimics clear. So this one, why we don't have to miss it. This is usually very common in elderly patient. Okay, because MI patient usually come with abdominal pain that is exactly like acute pancreatitis. So if you are going to do a differential diagnosis and you have an elderly patient, always put the MI if you're thinking that the MI is not the reason or the main cause or the most likely diagnosis. Please keep it as a third differential diagnosis if it is an elderly. Okay. So ASCII phrasing, my most likely diagnosis is acute pancreatitis, important differential including biliary pathology, perforated peptic ulcer, mesenteric ischemia, inferior MI, and other acute abdominal emergency. Then start justification for all of them, for each one, starting from the beginning, which is the most likely diagnosed, then the second one, the third one, the fourth one, and likewise. So diagnose and workup. For the diagnose, I think I did mention three things that we need to remember about diagnose of uh, acute pancreatitis. One, the characteristic of pain. Second, the enzyme abnormality or imbalance. The third, imaging. So these three we have to keep in mind. If we have 2 out of 3, we have the diagnosis. So what is the pain characteristic? Again, it is epigastric pain that gets better when you lean forward. it gets worse when you lie down in supine position, right? And it radiates to the back. So that is a characteristic pain for the pancreatitis. What is number two? Lipase and amylase level will go up. Which one is more specific? Lipase. If amylase is 3 times the normal, it is also acute pancreatitis. Okay, so I have the characteristic pain, I have the enzyme abnormality. Do I need anything else? You don't, but it's always good to have it. So, what is the image abnormality? If you see any abnormality that shows the patient has acute pancreatitis, good. If not, these two out of these three is more than enough. Okay. Now, initial investigation, CBC, electrolyte, always. So these are the things that we usually do for anyone that who is coming with an acute abdomen, especially in emergency case. We have to do all this, right? So imaging, do not rush to CT scan on day first. So this is very commonly tested, and the reason I put it in a different box with a different color because this is commonly tested and it's a common mistake by almost majority of IMGs that it is very specific. It is very helpful imaging. But remember, we don't usually do it on the first day. We don't usually choose it as a first imaging. First imaging is ultrasound. But the best one is CT scan. But we normally don't do it in the beginning, like in the first day when the patient show up with a sign and symptom. We usually do it 1 day later. The new update says it is better to do it 48 hours after the presentation of the symptoms because you get a better result of it. So it means that we do not rush to CT scan. If you have it, please take a look at the scenario. Is it saying that is it less than 24 hours or above 24 hours? If it is less than 24 hours, don't do the CT scan. If it is more than 24 hours, then it's good. You can do it if you want. But if you know that you have the diagnosis, then don't over investigate the patient. Okay. For example, do not rush the CT scan on day first if the diagnosis is already clear, so you don't have to, and the patient is clinically mild. Ultrasound is essential to assess for the gallstone. So you have it, don't rush it, and don't over investigate the patient. CT scan is most useful when the diagnosis is uncertain. If you're not sure, or if your patient is not improving within 48 hours or above 24, usually the best time for doing the CT scan if the patient is not improving after 24 hours, the best time is between 48 to 72 hours. Okay? Or complicated cases, obviously we have to do it. If they're asking you what is the first best initial imaging, always go with the ultrasound. And if they're asking you which one of the enzyme is most specific, lipase. If they're asking you, does the amylase show pancreatitis? If it is more than 3 times. If it is more than 3 times of it is normal range. So in terms of investigation, I think we did mention everything. I'm going to skip this part because we covered it. Severity and revised Atlanta classification. So for the mild case, there is no organ failure, no local or systemic complication, usually self-limited and short admission. Moderately severe. Now, transient organ failure, usually less than 48 hours. Local or systemic complications, needs close monitoring and reassessment. Now, for the severe, usually it happens over 48 hours, the severe form. And that's why we're doing the CT scan within 48 to 72 hours because the patient, if does not improve within 24 to 48 hours, it means it is complicated. Or it means there is something that we are missing that we cannot see it through ultrasound. So we need to do further investigation. Higher risk of necrosis, ICU need, and dead. Multi-organ support may be required. So severity predictor to mention early is the systemic inflammatory response, symptoms, rising BUN, hematocrit, obesity, older age, comorbidity, altered mental status, pleural effusion, and extrapancreatic collection. So these are very important and they are the predictor that shows the severity of the condition. I think I do have, yeah. So systemic inflammatory response syndrome in acute pancreatitis is presence early, especially if persistent, suggests higher risk of severe disease and organ failure. So if it happens, it shows that the patient is only getting worse, and there might be, not might be, there is a high chance of multi-organ failure. And how do we know the systemic inflammatory response syndrome? That if it exists or it is present, if the temperature is over 38 or less than 36, or heart rate more than 90, respiratory rate more than 20, or the PaCO2 less than 32, or WBC more than 12, or pandemia. So why does it matter in pancreatitis? Early or persistent SIRS suggests higher risk of severe acute pancreatitis. It means we need to treat it aggressively. Mention it with other severity clues. For example, rising BUN, rising hematocrit, uh, organ failure, hypoxia, oliguria, worsening vitals. Patient with a persistent SIRS needs closer monitoring and possible higher acuity care. How to say it in Nakoski? I would mention severity predictor, early, especially persistent SIRS, rising BUN. These are the things that the examiner actually expect you to verbalize it. They want to know, do you know the predictor, the severity predictor of acute pancreatitis? Do you even know if this is going to get complicated? Do you even know if you do not intervene right now, the patient is going to go to coma or death? Right? So you need to verbalize it, and the examiner expect you to at least mention it so that he knows that you know. Sometimes we think that this is easy. He knows that I know, so we just gonna skip it. No, they are not mind reader. Please mention it, verbalize it. I would mention severity predictor early, especially persistent SIRS, rising BUN, rising hematocrit, and any evidence of the organ failure, because these suggest more severe acute pancreatitis and need uh, and the need for the closer monitoring. Then the examiner will be impressed, and it's really heavily scored. So you don't want to miss out on that. So now let's talk about initial management. For the initial management, we always start, as I mentioned at the beginning of the lecture, we always start with the stabilization. Obviously, we start with the ABC, oxygen if needed, IV access, vital urine output, mental status, and hemodynamic assessment. Number two, fluids. Use the isotonic crystalloid lactate ringers is preferred. I made it bold, I made it red because it might be one of the question in the licensing exam in MCQ1, and it's going to be part of your management in the NACOSCI. In many guidelines, they are using this. So analgesic antiemetic pain can be very severe, treated promptly and adequately. Control vomiting to improve comfort and support hydration. Monitor, number four, monitor severity. Watch closely in the first 6 to 24 hours. The BUN hematocrit, oxygen, creatinine, the SIRS, and evolving organ failure. So once the patient is admitted, we keep on monitoring the patient to make sure that the patient is not showing any kind of or any sign of predictory sign and symptoms that shows that the patient is getting worse. So it means we have to do a close monitoring as soon as the patient is in, within the 6 hours to 24 hours, close monitoring. And we keep on checking these things that I mentioned a few times. Nutrition. So again, commonly mistaken by majority of IMGs to keep the patient NPU for as long as possible, which in mild cases, you don't have to keep the patient NPO. Do not keep patient NPO longer than necessary. In mild diseases, restart oral low-fat feeding within 24 to 48 hours. So basically, if the patient is mild, right? So the patient is going to show improvement within 24 to 48 hours. If it is moderate, the patient is not showing any improvement, and sometimes you can also see the patient is getting worse. But in severe case, after 48 hours, the patient is gonna get worse and worse. So within 24 to 48 hours, if the symptoms are showing to improve, it means the patient is getting better. So you need to start the oral feeding. Avoid routine antibiotic. We usually don't give antibiotic because not the most common, one of the reason for the pancreatitis is using antibiotic. We use it if there is infection, if there is a necrosis, or if there is any sign of infection, or we have an evidence that we need antibiotic for it. Cause-directed workup and management after stabilization determine why the pancreatitis happened. So why it happened. So order right upper quadrant ultrasound. Obviously, we have to do all this. If cholangitis present, early ERCP within 24 hours, decrease the morbidity and mortality. So this is very important. If it is cholangitis, we have to do the ERCP within 24 hours. I make it red. So if cholangitis absent, but a common bile duct stone is suspected, use the MRCP. So MRCP usually, it is used for diagnose. ERCP is used for the diagnose and therapy. So ERCP is therapeutic and diagnostic. MRCP is only diagnostic. MRCP is used when the patient is stable, but ERCP is used when the patient is unstable. So these are the difference when it comes to using MRCP and ERCP. In mild acute biliary pancreatitis, cholecystectomy should ideally occur before discharge. So do not do routine ERCP, and all biliary pancreatitis reserve it for the cholangitis or persistent obstruction. So it means if you have a pancreatitis, that the gallstone is the main reason for it, which is the most common reason. So it doesn't mean automatically that we have to do the ERCP. Why? Because ERCP is another reason for pancreatitis. We don't do it unless it is cholangitis or if it is persistent obstruction. We cannot fix it without ERCP. So in that case, we can use it. Other than that, we can just do surgery. We can do the cholecystectomy, right? So if alcohol is likely the cause, still stabilize and treat exactly as above. Supportive care remains the foundation. Ask clearly about the recent heavy intake, chronic use, periodic pancreatitis episode, and withdrawal risk. Plan counseling for alcohol cessation and relapse prevention before discharge. So if the cause is still unclear, think broader. Triglyceride. Have you checked the lipid? If not, please check it, because if triglyceride is more than 1,000, it means this is another reason or cause for pancreatitis. Calcium, have you checked the calcium? Because hypercalcemia is another reason. Medication, like the same way that acetaminophen causes, not the same way, but the same reason for liver failure is causing also or damaging the pancreas as well. All recent ERCP, trauma, autoimmune or hereditary cause, autoimmune problems or pancreatic ampular tumors, especially age, if age is more than 40, with no obvious etiology. Now, complication and what you must monitor. Early and systemic hypovolemia and shock, acute kidney injury, hypoxia, ARDS, persistent organ failure, ileus and metabolic abnormalities, bedside monitoring. So these are the things that we have already covered. Late or delay acute pancreatic fluid collection, necrotic collection, pancreatic pseudocyst, Waldorf necrosis, infection or infected necrosis, hemorrhage, venous thrombosis. Intervention is usually delayed when possible, especially in necrosis, to allow the demarcation. Infected necrosis is the classic reason for drain and uh, debridement. All right, so very commonly tested station. It could be history, it could be consultation, and it could be differential diagnosis and management. Probably today we're going to do all three of them. So if you are doing the, let's say, if you are the one who is the chosen for the history taking today, so how are you going to go about it? Remember that we have a mnemonic for the pain, which is OCD PQRST UV AAA. Onset, course, duration, position, quality, radiation, severity, time, your daily life, deja vu, aggravating factor, elevating factor, and associated symptoms. Then cover the review of the system. But remember, when you're moving from one part to another part, do not forget to use the transition. Okay? Transition plus consent, transition plus consent. Now I'm going to ask you a few questions about your past medical history. Is that okay with you? And the patient says okay. Even if you're not saying okay, if the patient says okay, it means the patient understand, the patient gives you consent. Okay? So ask about that and ask directly about alcohol. Why? Because it's most commonly or the second most common reason for pancreatitis. Do not be shy. Ask directly about the amount, about the time, duration, how long the patient is taking. Do not be judgmental, please. If the patient says I'm drinking 10 bottle of, like for example, a certain drink which is alcoholic, don't say wow, that's a lot. No, we're not here to judge people. We're facing this or we're dealing with this condition on daily basis. So for us as a healthcare professional, we have to like be unjudgmental. So if they say like 10 beers a day, okay, have you ever thought about it? Have you ever thought about cutting it down? And the patient say yes or no, or maybe I'm thinking about, I'm not sure, but just gave them reassurance that we have all these service for you. This would be very helpful and treatment or management plan that we have for your pancreatitis, because this is the most common reason. In your case, since you're drinking uh, like 10 beers per day, this is the most common reason. So no matter how hard we work to treat the pancreatitis, if we don't address the main reason, which is the alcohol, it's not going to be beneficial. So do you need any assistance in that area? We will be more than happy to assist you or consult you or give you the brochure or whatever. Just provide them with all information that he knows that there is assistance for them and you are supportive and you will be there in every step of the way to help him quit or cutting down on the drinking. Okay. So ask directly about the alcohol, about the gallstone. These are the two most common reasons. Then ask about if the patient had the biliary colic or gallbladder issues before, and has he ever done any sort of investigation like ERCP? So why? Because these are the cause, right? We have to go after the cause. Medication, what kind of medication the patient is taking, that will be part of the past medical history. And also ask if the patient has checked his lipid profile and what was the range if he remembers it. Okay, because we know if the triglyceride is more than 1000, it is the reason for pancreatitis. Screen for jaundice, fever, confusion, dyspnea, oliguria, and GI bleeding. Red flag, do not forget, you have to cover it. The key sentence, I would like to take a focused pancreatitis history and actively look for the gallstone, alcohol use, and other red flags. Okay, consultation. For the counseling, explain that the pancreas is inflamed and can range from mild to serious. Okay, so in a very lame language, we're letting the patient know, we're consulting the patient or educating the patient that you have an organ that is called pancreas, and this is the job of the pancreas. Usually, this is what it does, but this organ is inflamed at the moment. And if you know what is the reason, you will say, since you're drinking 10 alcohol or 10 beers per day, that might be the main reason. Or you have a gallstone, which is the main reason for this inflammation. Or you did this ERCP recently, that could be the reason for it. And that's why we have acute pancreatitis. Reassurance, honestly, most need admission because complication can evolve the first 24 to 48 hours. If you have acute pancreatitis, do not dismiss the patient because probably the patient is taking a few painkiller, morphine, or the patient is drug user. He has just got his medication, I mean the heroin, whatever he's using, or the cocaine. He's not feeling the pain right now, but within 24 to 48 hours, the complication may happen and the patient may not make it to the hospital. So we need to admit the patient and we need to, and when you do the consultation, this is one of the reasons that you will bring up if the patient says, why can't I go home? Just give me some painkiller, I go home. You need to let him know that's the main reason that we keep you because the complication may happen within 24 to 48 hours. So that's why we keep you here and we monitor you. We do these tests that we need to do in order to find out the main reason or whatever you need to do. But you need to mention this part, which I made it red and I made it bold so that it stands out, and don't forget it when you do the consultation. Tell the patient you will control the pain, give fluids, monitor closely, and identify the cause. These are the things that we need to mention because the patient needs to be educated that if you keep me in the hospital, what are you doing? Why you keep me in the hospital? So I keep you in the hospital for these reasons. I need to run these tests. I need to do this. And I just to be on the safe side because the complication happens within 24 to 48 hours. That's why. Okay. Key sentence. This is inflammation of the pancreas. The treatment is mainly supportive while we look for the triggers and monitor for the complication. Now, differential diagnosis. If it happens that you are the one who is doing the differential diagnosis and management, so if it is a combo, you just do a transition. If it is a specifically solo station, then you have to go ahead and do all that introduction and ID and so on and so forth that we all know that. Open with the diagnose. We always say this is the most likely diagnosis for these reasons. A, B, C, D, whatever you have, justify them and back up your diagnosis. My most likely diagnosis at this point for this patient that who came with the chief complaint of this issue is this. Why? Because the patient had this. And then my second differential diagnosis this because the patient had this option but doesn't have this sign. That's why I put it the second one. And the third one, then justify why it is my third differential diagnosis, explain it, the clues that matches the characteristic of the pancreatitis, but why you put it as a third option or third differential diagnosis? Because it doesn't match this side of it. Or this, for example, the patient does not have vomiting. The patient does not have pain radiation to the back. That's why I don't think it is going to be pancreatitis. It is more likely it's going to be something else, whatever. So the key sentence, my immediate priorities are stabilization for the management. Obviously, I have to stabilize the patient first, then diagnose, severity assessment, and cause-directed workup. Just to sum up and wrap up the whole lecture, how to diagnose? Three things. For acute pancreatitis, we need three things. One, the characteristic pain, which I did mention it. The patient will have a pain, epigastric pain, gets better when you lean forward, get worse when you are lying down in supine position. It is radiating to the back. So characteristic pain. Two, lipase and amylase. Lipase is more specific, but if amylase is more than 3 times of its normal range, it is also specific. That's the second one. The third one, imaging. If the imaging shows that the patient has pancreatitis, that's also diagnostic. So if I have 2 out of 3, I have the pancreatic diagnosis. I don't have to have three of them. If I have, that's good. If I don't have, two is more than enough. Top causes. We have a lot of causes for the pancreatitis, but two most common reason is number one, gall stone, which is 45%. Two, alcohol. Initial management is always stabilize the patient, ABC, IV fluid, analgesic, antiemetic, and monitor. Monitoring as soon as the patient is admitted, you have to keep checking uh, the the CBC, the lab, and all that to find out, and also the vital signs. Keep on checking it within the 6 hours to 24 hours to see if the patient is showing any predictory sign of severity. It means, are you seeing any sign of the patient getting worse or no? And you know how to check that. I mentioned it before. So no routine prophylactic antibiotic. We don't use it. Why? Because the antibiotic is one of the cause for the pancreatitis. We do use it when we need it, or when the infection is suspected, or necrosis. Early feeding when tolerated. So usually we don't have to put the patient for NPO for a very long period of time. If the patient shows improvement within 24 to 48 hours, we have to stop NPO. We have to encourage the oral feeding. ERCP if cholangitis or persistent obstruction. So usually the ERCP is, if we have a gallstone, the ERCP is a good choice, but it doesn't mean that always we have to jump right to the ERCP. We usually use it when we have persistent obstruction or cholangitis. Cholecystectomy before discharge and a mild biliary causes, if that is the case, and Nakoski structure plus safe answer is equal to really good marks. And thank you very much. I hope you guys